Hey, good afternoon and welcome everyone to the Dick Hamman Lab. And we are privileged to welcome Dr. Alfredo Morabia to our university and to the Colorado School of Public Health. So Dr. Morabia is a professor of clinical epidemiology at Columbia, at Barry Commoner Center for Health and the Environment at Queens College, City University of New York, and also at the Mellman School of Public Health, Columbia University. Probably known best as editor-in-chief of the American Journal of Public Health, and he completed his undergraduate studies at Calvin College in Geneva, majoring in Greek and Latin, and from what I understand, you still in Latin. Okay.
I can.
Very good and very impressive. After receiving his MD from the School of Medicine at the University of Geneva, he trained in internal medicine at the University Hospital of Geneva and occupational medicine in Italy. He is board certified in both internal medicine and occupational medicine, and in 2009 was appointed fellow of the Royal College of Physicians of Edinburgh. In 1986, he received a grant from the Swiss National Science Foundation to study at Johns Hopkins, and where he obtained an MPH and PhD degree in epidemiology. Welcome. We're looking forward to your talk. Thank you.
Thank you very much, Dean Bradley, for the introduction. It's great to see people that I saw this morning, and I took extremely interested by this conversation. And of course, my dear friends, John, Samet, and Connie, very close for a very long time, and we have lots in common besides Latin and Greek. So thank you for inviting me to give this lecture. I'm extremely happy to give it. I have to tell you that on the lessons of COVID, I'm on the very positive side. I try to say it in one way. I think the response, the public health response during the pandemic, against all odds, against lack of preparation, against marginalization of this across several administrations, with an administration that was really, to say the least, not helpful. I mean, the achievements over those 2 years have been beyond any expectation. If you had asked someone in 2019, what do you expect to see in terms of vaccine coverage or response to the public health recommendation? No one would have predicted that on the basis of the record of public health in our country. So I know what I'm going to say is very positive. I'm kind of bragging about what is happening, but it's just another side of the story, because you surely hear a lot of other interpretation. So I actually wrote a book about during the pandemic, like many other people, called The Public Health Approach. And the reason is that I think one of the obstacles for an even greater impact was the the lack of understanding, not misunderstanding of how we think in public health, of what's population thinking. No one is a population thinker spontaneously. We have to learn that there is a population dimension, that you can learn from by comparing population that you can never learn from comparing individuals, that our natural psychological growth is to think at the individual level, and to use anecdotes to extrapolate and to build theories about that. My neighbor got the vaccine, died 2 weeks after, then it means that the vaccine kills. That's individual. If you have a population approach, you try to see what are the probabilities of the events, what you would expect in a population that that person would have died during that period of time, and you compare with the probability that the vaccine actually killed that person. So knowing that there is a population dimension from which we can draw evidence, and that we can understand phenomenon at the health level that we can never understand at the individual level, something that no one can reach. Either you've looked at data and you've learned it, or you've been trained to do that. So how would the public know how we think without any training? So that's the idea of this book. It's a very small book in which I show that this switch from individual thinking to population thinking is key to understand public health, and I give historical example. So the three main lessons that I would like to share with you is going to be a short talk because I would really like to have the conversation. The first one is that we have to prioritize approaches that provide access to public health to everyone. The second is that we have to formalize, and I've discussed this with many of you this morning, the participation of the community or the citizens to not only the production of science, but also elaboration of policy and implementation of this policy. And so I'll develop more later. And the third is that we need to teach population thinking, and the earlier, the better. So let's look at those different. The first one has to do with the successes and the failures of the public health response. I think the successes are obvious, and how even Nature in an editorial in 2021 wrote how epidemiology has shaped the COVID pandemic, because really very rapidly we had all those epidemiological results that were telling us about the dissemination of the pandemic. This was in January, of the characteristics of the infection. You remember the days from infection to the first symptoms, those 4 days, the days from infection to hospitalization, that was the 11th day. I mean, all this information was available extremely rapidly, and they required the analysis, the quick analysis of a lot of data. Key information that the group at risk, the higher risk was in older people, was a key information that came very early. But I remind you that in 1918, when the Great Flu, this was not the same distribution. I mean, there was a very high risk among people, teenager and young adults, for a different reason. But knowing that people 60 or 65 older were at greater risk of dying from COVID was a key information. And as I will show you, that has been, extremely well used across all the country. And rapidly also we had information about the effect of mask and other personal protection. So, and these are in the first weeks or months after the beginning of the pandemic. So these are no doubt huge successes. If we talk about the statistical models, we were ready because we had failed in 1980 when there was the HIV epidemic. Epidemiology has been taken totally by surprise and had missed the boat. But there we were ready for an infectious disease epidemic. the R0, the case fatality rate, which were the high-risk groups, fact of isolation, of quarantine, important infectivity of the variants, the effectiveness of the vaccine tested on a very large scale and very quickly. So these were major successes that occurred during the pandemic. But there were failures, and of course, you know, there were all the criticism that we can have about how the country responded to the pandemic. The number of deaths could have been lower, but there were also major failures that can be, I think, related to one important weakness of our system that is still not resolved. So one of the two big failure was that impact of the pandemic was extremely unequal. And when people were saying we're not all in this together, we had a cover of the journal saying that's not true. We're not all in this together. Some parts of the population are much more affected than other, and there's been huge inequality. But I think that part of this phenomenon is due to the fact that we were not able to track evolution of the pandemic, that we didn't have the instrument for the monitoring of the evolution of the pandemic. We have never known what was the proportion of asymptomatic infection, because there were no randomly tested sample of the population. And so part of the fact that some population were more impacted than others were also related to the fact that we could not track the disease. And this article in Politico called "Inside America's COVID Reporting Breakdown" was quite telling that COVID-19 was spreading rapidly throughout the United States as cold winter weather began to drive people indoors. But the Center for Disease Control and Prevention was flying blind. And I love this expression because I think that's exactly what happened when you don't have the appropriate dashboard. State agencies that it relied on were way behind in their tracking, with numbers trickling in from labs by fax or even snail mail, and convenience sampling, not a systematic sampling and testing of the population. That was a moment of hope when Rochelle Walensky decided that she wanted to improve the system of collection and what we often call and still call surveillance. I'm trying to move it to health monitoring because I think it's a term that is better understood by the public. But she was also, doing a very bleak, description of the system. It said fewer than 200 health facilities across the U.S. had their electronic health records linked to CDC data collection systems before the pandemic. At the start of the pandemic, some states that were unable to electronically report positive COVID-19 cases had to fax, and we know that story very well. And some states were entering positive results first because they didn't have the capacity to enter all the negative ones. So what we had, our perception of the evolution and growth of the pandemic was totally wrong. And if you don't know where the pandemic is and what's the proportion of the population that has been infected, it's very difficult to decision. And it was very interesting at that time to see that, for example, Britain was changing its plan by changing the proportion of asymptomatic cases, because indeed the case fatality rate would change dramatically according to what its denominator would be. So that was very important information that we didn't get. but it was possible to get it. And we insisted in the journal, there were exceptions, and there were very important exception of population-based of the evolution of the two cases are one, Spain, and Spain had a national program that was based on sampling, random sampling of the population. They were going to the houses and knocking at door and taking blood, and they were able in the summer of 2020 to report not only the progression, the prevalence of the infection in different group, but they also knew that about 30% of the was a very key information. And that system is really remarkable. And hopefully they will be able to now that the pandemic gone. And the second system was in Britain. It was called React One, and they had they send their kids for testing every month or 2 months to a very large sample of the population, and they were able to report, the progression of the pandemic and the seropositivity in the total population, and this is by age group and by region. I really recommend that you read those articles in last year's issue in the journal, because those are tremendously important example. And if you don't fly blindly, then you can start, and I hope we have the conversation later, but in my perception that when you know how the disease is progressing, you can start to act precisely, and you don't have to close schools and to close small businesses on a large scale just because it's more cautious to do it, but you can act consciously. And that's what we were missing. And this is an example of a Spanish university. Well, if you have the information, you may not have to close the school, you can leave it open, but you can actually have the evolution under control. So I think for me, the major failure of the whole pandemic was the lack of health monitoring system that could track the evolution of the pandemic. And for this, we needed random sampling, monitoring, we needed standardized surveys across all states, protection of data, unique patient identification, the whole system that was actually not available in this country, and that hopefully will be available for the next one. So that's the first lesson. There were great successes, but there were also major failure. And I would see the main one as being the lack of health monitoring system that would allow us to track the progression of the pandemic. My second lesson is about the vaccination campaigns, and I call them historical success, so we can talk about why historic, and you recognize those maps. This is among also 18 plus vaccine coverage, and this is 5-year plus. And so you see that the state was extremely well covered. And when we talked this morning about Washington, but vaccination campaigns were a historical success. And I remind you that in 76, was a disaster. The vaccinated people was, and then there was all the controversy about Guillain-Barré syndrome, etc. I mean, it was a whole disaster. We didn't have this this time, and if you look at the results overall, this is for Colorado, and you take the people age plus completed, fully vaccinated, 82%. The 65 plus, 99.9. Excuse me. How would you, predict this type of thing? And this was very similar to what the country did. And if you take the adults here, 79% of the population, 79% the population were fully vaccinated, and 94.4% of the people 5 years older. And this is the adults, 80 year plus. Every state had more than 50% of the population vaccinated. Every state. The lowest achiever was Wyoming, I think, with 53%. Remember exactly, but they were all above. But now this is really interesting. This is in the 65 plus. The whole country was vaccinated. The lowest achievers is Arkansas with 83% coverage of its 65-year plus. I mean, people may have said they were anti-vaccine, they were shouting, etc. They did the job everywhere. Everywhere. They knew 65 years plus you were at higher risk. They were not getting their population killed by the virus. They knew the vaccine worked, and they did it. I mean, even in places where the public health system is much weaker, like for example, Kansas, they had this special program with CDC in pharmacists to actually do all the vaccination. But there's a lot of things that I'm just going to be there, but it's been done. Who in 2019 would have predicted this? That's fabulous. I mean, and besides everything that can be criticized, this is a result. And I was in Texas not too long ago, and they had also 99.9% elderly population. There was this county here, King County, which is almost white, and it looks a little bit like Washington County. But I'm going to show you this because if it's true that 95% of the population, doesn't mean that the 5% left didn't want to be vaccinated. Because let's go, I went to visit King County, and but if you go on Google to King County and you really put Guthrie, which is the center, how do you call this, the main city of the county, okay, that's where Google tells you you've reached your destination, right? So it's prairie all over, and you are in your truck, you have your cold vaccine in the back. What are you going to do? You go to the next place. And so that's so, and everywhere I go, I went to Alaska, I showed places. It's just impossible. And we can look here, why Washington County had only 40% of that. There are 5,000 people living. Really, I won't take you there because but I could. But anyway, so there are places that are hard to reach, when circle. There are places where physical distancing is just part of their way of life. I mean, there are different reasons for why people have not been vaccinated. So the success on the positive number is not complemented immediately by those who didn't get the vaccine. Doesn't mean they were hesitant or opposed or anything. It's much more complicated. But that's only one part of the side of the success, because the other part is that how many defects have been, how many anaphylaxis, thrombosis, Guillain-Barré syndrome, deaths, very few per millions. So you have this huge coverage of vaccine with very, and we should be bragging because I don't know when we'll get another chance like that. It's been really opportunity to show how public health works, because how do you explain that the vaccine can go from the warehouses of the pharmaceutical arms of the people? I mean, it's not the generals, even if they useful, but they were in the White House, that would make that. They can guarantee that there is some quick transportation of the vaccine warehouse to the places, to the states. But then, you need to have refrigerate, identification of the people you're going to invite, registering them if they once they're vaccinated, certifying them, collaborating with pharmacies, with private sectors, offer the vaccine tons of I mean, who can do that besides public health people? So it's certainly not the people that were leading the response at the federal level. So it is definitely a success and a big achievement of public health. And we did it because of the sense of mission, because we all reacted, and because we were trained for that. And if you don't have this training, you cannot do it. So again, I think we should brag about this. People should run for office on claiming, the number of people, hospitalization they saved, number of deaths they saved. This was in September 21, 27 million infection prevented, 1.6 million hospitalization, 235 deaths among vaccinated. That's big number. And you can imagine the impact of those if they hadn't been prevented on our healthcare system that was already trained maximum. And for me, the lesson is that, public health has a great support. And we can discuss later, but I think it's never been as large as it is today. Time we have the numbers, people voted with their arms. It's not just, thinking about who is in favor or against. There is a huge support, and that's why it's very important for public health services to be accessible to all. And for this, they need to be the law. They need to be enforceable. If public health is not enforceable, it's not public health. But it needs to be, and the large majority of our population wants to receive that support. My third, so that was the second. Vaccination show how effective public health is, but also how supported it is. That's how our responsibility is to make sure that everyone has access to. The third lesson is that we need to include everyone. It happens that historically, when you look at it, there is no ideology that has an exclusive, that excludes some sector of the population that is compatible with public health. As soon as you exclude people, whether, they be immigrant, whether they be Jews, whether they be, Romas in Europe, whoever, once you start excluding, or on the basis of the sexual orientation, once you start excluding and not considering the whole of the population, public health fails, because it only works if we include absolutely everyone. And so I give lots of examples in my book, but there is one example that I really think that, makes the point of the reasons for non-exclusion. And This was a very good article published in by the National Bureau of Economic Research about the excess death rates for Republicans and Democrats during the COVID-19 pandemic. I want to stress that this is a cohort study. The political preference was determined on electoral registries, and the individuals were followed up in the mortality registry. And it was done in Florida and in Ohio. And so they used excess death, which in my view is the best measure of the impact of the pandemic, because all the COVID-specific indicators, they are biased. So the excess death, those authors, they looked at the excess death in 2020 after the vaccine was introduced. As you may remember, once the vaccine was available, most of the new cases occurred in non-vaccinated. And the vaccinated are here, and most of the deaths occurred in non-vaccinated. So their hypothesis was that, well, Republicans vaccinate themselves less than Democrats, so they should die more from COVID related deaths and in terms of excess mortality. And so they designed their study very, very nicely. They're economists, but they're very good. You know, I know they took it excess mortality compared to 2009. Reds are, of course, the Republicans, and the blue are the Democrats. And if you look at the excess deaths per month or in 2018 compared to 2019, you see that there is really the two groups are comparable. It's not that Republicans and Democrats were different in terms of their mortality risk. They were very similar. And then we entered the pandemic, and before the introduction of the vaccine, there is very little different. But once the vaccine is available in 2021, there start to be a difference. And when they take it in January 2022, there is a 20%. Here you can look at the other. So Republicans began to die more from COVID once the vaccine was available. And frankly, there were half of the deaths, 5,000 occurred before the vaccine, 5,000 occur after. And Republicans have paid a huge price, second part. And when I see at some, show, demonstrating in front of public health departments or city halls, no one goes and follow them, but many of them are probably not there anymore. And that would be an important thing to follow up. So the data in this study had this very important results. So let me explain to you what we see here. So this is the prevalence of vaccination in counties that could go from 20 to 60. And so this it was, of course, measured in 2021, but if they take the counties and their prevalence of vaccination and look at the excess mortality for the introduction of the vaccine between Democrat, there's no difference. So whether a county became highly vaccinated, 60%, or poorly vaccinated, 20%, there was no real difference. After the introduction of the vaccine, then we see differences. And I think that's the most interesting part, in counties that with more than, the half of the population vaccinated, there's no more difference between Republicans. So there is a protection of the whole community that occurs when a large fraction of it is vaccinated. In the counties where there were a lower vaccination, So they were mostly Republicans and the mortality much higher. So, I mean, COVID kills Republicans. Do we care? So you see, that's the reaction that we have. But yes, we care. Because it's a totally non-public health reasoning to think that we can exclude, because once we have a fraction of the population, then then the virus stay longer. There are more variants. There are more small business bankrupt, etc. So yes, we care. We care that everyone is involved, and I had an editorial about that. Why we care that Republicans die more? Because of course, no, that's not. We should care about Republicans dying more than Democrats. COVID-19. Public health includes everyone, Republicans, undocumented immigrants, everyone. And this is also what's fascinating about our job. We need to reach everyone. Only if we include the whole population. It's difficult, it's political, but that's the interesting challenge. My fourth lesson is about participative research and policies, essentially the importance of having a bottom-up it's very important. In my view, it's one of the when we talk of problem of communication, when we talk about problems of hesitancy, when we talk about failure to reach some population, one of the important component of that is that we didn't listen to what their view and how we could do this very well. So I'm going to give you an example you all know, but it's just for me, it's the typical example of a public health policy that should have worked. Everybody agreed. You know, you want to take away, you know, those big cups of soda from Harlem or from the Bronx, etc., where the children have 50%. Of course. Okay. And so Bloomberg and his public health department decided to ban those big cups. And so that if you wanted to have that amount, you need to cups, but you was just banning in order to have children have less access to. Well, it was it failed. The New York City Department of Health ban failed. It failed at justice level. There was a judge who considered it had problems and too many loopholes, and it was ill-conceived, and so they couldn't implement it. But you know, some people went and asked the community why. The community reacts so strongly, and the leader of the NAACP, Ben Gillis, you know, was interviewed about this, and he said, "Of course, we're in favor of that, but brother, come and talk to us. You know, let's see how we can do this well." Your project are going to be a huge problem. People may feel discriminated because it's only the Black kids and not the white kids, etc. I mean, there were too many problems. We can, if you integrate the community and its perspective, you can do things well. And this could have been a huge success had they taken the time to include the community and have it participate at all level, including, you know, what it meant economically for some of all businesses in the community. So come talk to us. Let's figure out how to do this together, Jill said, rather than pitting us against each other. So that's not the pandemic, but it's something that is present all the time. And it's a huge, that component of public health is really one of the two pillar on which it needs to be built today. There needs to be an institutional public health, but also a community-based public health. Formalized, organized, trained leaders, and function as a complete part of the system and not only as a optional addition. And we have lots of lessons, you know, from LGBTQ, labor unions, nothing about us without us. That every public health student needs to understand. But it won't occur alone. We need to organize it and formalize it and train. And so that's one of the our great objective. And I think that had we had done this during the pandemic, things would have been even better. And I mean, in the journal, you'll find a lot about feminism, you know, our bodies, ourselves, also about the integration of faith-based organization. When there are multiple faiths, it's even better because, you know, they're really focusing on the public health and not so much on think to their own faith, and they're really effective. And we thought about those organizations, their ability to reach them as they get. So, and I want to mention these two supplements. I'm very proud of them because during the pandemic, NIH and NHLBI and NI, MHD, they funded a project based on community-based community engagement. And they got a lot of data and they came to us and they say, we want to publish it. And it was unpublishable, you know, most of it. But the journal, the editor, we invested a lot in that. And we came out with a good number of articles and reports that is an anthology of how you have to conduct this type of research. This was for testing, was called RADEX Up. Up is for underprivileged population. And the other one was SEAL, and it was about vaccine. And same thing, the material at the beginning was not great, but we what had the best potential, and we presented very rigorously. This is all quality level of the journal, and I hope they will be read a lot because I think it's remarkable that those federal agencies chose that direction in the middle of the pandemic. In terms of methods, and I talked with some of you, I mean, there are fascinating methods to actually work with communities, integrate them in the research, and actually use the research as a means for transforming the community itself. You know, intersectionality is something we're very strong about in the journal. There are other methodologic theories, but it's a combination of research and praxis. It's kind of there's a philosophy inside. It's not something you would get in a 1 hour speech, but the young people that are doing, and they approach very complex situation, a lot of confidence, and press Mueller. So my last point is about becoming population thinkers, and you may know this logo, I hope, because that's our role. And here is my example of why we should be. What killed Hank Aaron? So who is Hank Aaron? I don't want to insult you, but of course, maybe you may not know that Muhammad Ali said about Hank Aaron, he was the only man I idolized more than myself. All right, that's not an understatement, right? So here is Hank Aaron when he was in the Braves in Milwaukee. They were that's and Hank Aaron, as you know, immediately when the vaccine became available, went to Morehouse and got it publicly in order to give an example. And so 2 weeks later, Hank Aaron died. He passed away peacefully in his, according to the now Atlanta Braves. And so what's the natural, spontaneous reaction of any human being? And believe me, I really mean it. Any human being that has not been trained for that would think Aaron was vaccinated, he died shortly after, therefore vaccine kills. Because that's how we think. It's and it's just an anecdote, but we tend to extrapolate for anecdote from it. Maybe there is some natural selection explanation for that that we need to think quickly. But that's how we think. And I don't want to insult you with a very simple example. So excuse, but it's just for the logic of my demonstration. So it's the same thing as saying my 92-year-old neighbor smokes a pack a day and he's still alive. So it's not true that tobacco kills prematurely. 92 years and he's not dead. So I don't believe you. And indeed, in our personal experience, most of the heavy smokers we meet don't get lung cancer. So 10% of them over their lifetime will get it. But on 200 people, I you see in a moment why I use 200, 180 will never get lung cancer. So in our personal experience, there's no way to say that tobacco causes lung cancer. And the 18th century philosopher, they were first dealing with probabilistic event, they would have concluded no, because the causal relationship is commonly following it's only when we compare populations, those that smoke one pack a day with those who never smoke, that we see a difference. And this is how we can tell there may be a causal relationship here. Because if the same people had not been smoking, they would not have had as many. So at the population level, we can derive some conclusions that are impossible to derive at the individual level. So if we take this logic, apply it to the Aaron case, so we have to ask ourselves, what was the likelihood that 86-year-old then would have died that week, independently of the vaccine? What was the probability that that man would have died that week anyway? And we can get the data. There were 11 million people that had been vaccinated age 65 or more, because this is Framingham Heart data. I'm trying to get the exact data for that age group. But for now, Framingham Heart Study had 65-year plus, 11 million people had been vaccinated. The expected cardiovascular event was 0.04% per week. I had the data in years and I derived it per week. And so it means that in 3 weeks, we would have expected about, in the country, 15,000 cases of cardiovascular diseases, and age 86 or likelihood that they lead to death. So that was one thing. There were a large probability that Aaron would have died from cardiac event independently of the vaccine. So now what is the evidence that the vaccine could kill it? And you know, all the evidence is that the vaccine protects. In the unvaccinated and those with a booster, it's very clear. The mortality rates are. So the vaccine protects. The likelihood of death was very high independently of the vaccine. So we can conclude based on our approach that Aaron died of heart and independent, and this was not related. So that's, you know, that's population thinking. And again, no one, and if you believe me, I know John, but no one in history, no one, I mean, if you think of all the great doctors of Hippocrates, of Gallen, or imagine that they could be a population dimension. You needed 50 years of mortality data in London in order to observe it and to discover it. So today, you cannot be a population, or if you don't actually analyze data. And you know, the continuity, I mean, what discovery of population thinking on ground in the 70s. That casualty is random. How can I predict at an individual? How can I predict who's going to die next year? But at the London level, why, as I think population thinking should, as in colleges, but also because that's where they learn the truth, you know, chemistry, physics, population thinking. All right, so that was.
Okay, thank you for that terrific talk. So there were three things I really liked about it. It was nice to hear the positive side of public health and everything that was accomplished. That was really wonderful. And then this whole aspect of population versus individual thinking, and that's just not consistent with our country and our culture. But to be able to think that way and to infuse the methods, the evidence base, and to be able to do that, I think is incredibly insightful. And then the third thing I really liked about it was an epidemiologist said something nice about economists, which doesn't always happen. So I appreciate that as well. So this part of the talk, we're going to turn to our panel. We have 4 members of the panel. We're going to start with Ned, our Associate Dean for Public Health Practice. Also, you have a role in CDPHE as the Chief Medical Officer. So we're going to start here, go down toward the right, ask you all to introduce yourselves and to provide a couple minutes, a 2 or 3 minute reaction.
That was great. I really enjoyed it. I had a few observations. I too like the fact that we actually really did well. Those are higher immunization rates than we've seen with the flu vaccine, where Colorado's traditionally done well in the low 70s. So that's remarkable. And it was great to see that story told. As I was thinking through the population health approach, I remembered H1N1 avian, which was during my first round at the health department. And there was a different feeling at the time. And so we could actually talk about community resilience and helping your neighbor. So the issue that as part of a good citizen, your role was to wait until your turn on the vaccine, actually was a message that played well in print media and broadcast media. Now, this is before the other kinds of media. So social media and echo chambers and channels had not been an issue. But it was remarkable to me how well that played and how it did not play out in the pandemic. So I started thinking about that and the challenges towards moving to where we should move. And maybe it just does, going back to high school. There are a couple things that I remember is how short our memories are. So we had a big infusion of money into bioterrorism and pandemic preparedness after October, the October after 9/11, when anthrax letters killed 7 people in the United States. And I always take that 7 because think about 7 out of 300 million versus the mortality rate from tobacco. Had we put a fraction of the spending into tobacco cessation, the number of lives that have been saved would be immeasurable. But that's not the way we think. It's like this issue about the rare event captured that we have no control over. We had no decision making that captures our imagination and makes us act unusually. So if you follow, we did this at the National Academies, if you follow spending for emergency preparedness, it kind of tottered along during the Bush years and then started to drop off. And then it kind of went down, and there was a little bump with MERS, if you remember MERS, and then blah, blah, blah. And then a little bigger bump with Ebola. And then in the last year of 45's administration, he cut all funding to emergency preparedness at CDC was gone in a year. And then the pandemic hit. So there's this issue about how can we think population and be prepared and somehow keep some level of preparedness, even to gear up quickly for the next event. This drop off has been even faster for another reason. We had pandemic fatigue. And so we were talking a little bit about this beforehand. No one wants to talk about the pandemic. It doesn't seem like anyone other than public health wants to learn from the pandemic because the fatigue is so great and it's fueled by this. You even said it, it's over. It's over. So I don't want to think about the next pandemic. I don't want to think about there would be. So how do we change that level? This is for all to think about. Capturing that concept of population level thinking, how that could translate into a sustainable or readily recreated sense of preparedness in response to the next pandemic. So that's one of the issues I thought. And the other big area is misinformation. So it gets back to social media, echo chambers, and channeling. Everything, I mean, I think I would say we're the choir. It all made so much sense. And we just said, oh, of course. And I think about, there's a public health director who is an RN, recent graduate, in one of the counties in Colorado on the Western Slope, who refuses to have her health department give COVID vaccine because she had someone she knew died because of the vaccine. That is misinformation. That's false news. It's the Hank Aaron effect automatically. And I think about this person and I'm not sure there's anything I can say. Maybe it's too late, right? Because this person didn't get population thinking ingrained when it was the truth. I have no way of using, I believe, in using this presentation to say, look, you might not be correct. So that issue, the other challenge I think about rather than our short memory and we want it to be over is this issue of someone called it cognitive um, um, cognition, an almost faith-based belief in something that's wrong, like there's no climate change, or vaccines cause autism, or this COVID vaccine is more dangerous than it's helpful. So I think as I think about school, and maybe it ties back to grade school, is how do we address this short-term memory, our unwillingness to pay for unused capacity in the United States preparedness. And now we have laid over it this whole level of very effective misinformation. So I love the talk and I'm uplifted, so that's really good. And those were my kind of thoughts as I went through it. So that's not to ask questions, I think, but that's my observations. Oh yeah.
Thank you very much. And so on the two questions. First of all, pandemic fatigue is a historical, very common phenomenon. When the plague epidemic stopped in the early 18th century, all the quarantine activity and the protection, I mean, people didn't want to hear about it and they got rid of it and they were fatigued by, several centuries of recurring plague. And same thing occurs after cholera. There were a lot of protective aspect on the water, etc. And after that, people stopped. And this fatigue is just completely normal. And what I think that, and in 2018, we had in October, the issue of the journal was about the coming,
Yeah, I remember.
plague, because it was 100 years after, the flu and the Great Flu. I think this is almost impossible to prevent. But now there is one thing that I really believe that we can have that would allow us to be much more ready, much readier if there is a new phenomenon of this type, or even for everyday practice, and it's the health monitoring system. And I talked to John Kasich once, who was the Ohio governor, former. I published the interview, and I, asked his belief, because he's a supporter of public health, and but he sees it really locally. He's against the federal government, and I said, but what about health monitoring? And he immediately says, data, that's the federal government. And it just, and when you talk to Kasich, you have a heavy weight in front of you, I mean, everything he says is like a big punch, and when he was punching me, I was feeling it. But there, his reaction, and so I think there could be bipartisan support for health monitoring. That's why the journal, I moved it from surveillance, because Republicans, when you say surveillance, they think police, and they, in Congress, they have the surveillance, the law, et cetera. So something we should, so health monitoring. And if we could have a state-of-the-art health monitoring system, we would be much better, much better. That was one. The second was, health communication. I believe that, bottom-up public health can answer a lot of this. And I have one example. What happened to the working class of, the center of the country, Appalachian, Utah, and other parts, which was working in the metal mechanic industry, in all those industries that were thriving in the 50s, 60s, and then became bankrupt. Later, atomic bomb, etc. Producer. And so what happened? These people were working in their plants. They had labor unions. They were socializing through their work, and the unions brought them the information on many aspects that they wanted to know about. And all of a sudden, they were alone home. And the only information was TV and social media. And this was before the pandemic. And that's where a lot of the former president support grew, you know? I mean, when people are isolated and don't have this trust relationship with some organization, you know, they become victims in a much easier way than if they are organized. So building on community-based organization, frontline organization, grassroots, you name them, religious organization, I think can help a lot preventing the importance of the disinformation and the misinformation.
Thanks.
And then if I could add just a comment, we aren't particularly trained in communication in our own field. And as scientists, we could certainly do a better job. Whereas those who are peddling disinformation certainly are well-trained in communication. Okay, going to Bill.
Hi, Bill Berman. My perspectives are predominantly those of somebody who worked at a local level because I was the chief medical officer for Denver. I was also on the executive leadership team for a big healthcare system, Denver Health. And then the third part of my experience was I was a co-chair of the Metro Denver Partnership for Health, which was a partnership between the health departments in metropolitan Denver, along with healthcare systems and social service agencies to a lesser degree. And a couple of reactions. I think there's sort of the moments that are really vividly stamped in my mind from the pandemic that really relate to some of what you talked about. The monitoring system is the first one, because I can remember very clearly the Sunday when I was at work and things were coming apart in northern Italy, and I thought, oh my goodness, it's coming here. It may be here already, and I have no way to tell the boss, that is the citizens of Denver, is it here? Is it getting worse? Is it getting better? Whom is it involving? We had no monitoring system, in essence. And sort of the duct tape and baling wire approach over the next few weeks in casting about for some way to measure what was happening was two things. One is we had been an early participant in syndromic surveillance from emergency department data under the leadership of Art Davidson, a brilliant informatician in our department. And we figured out, along with CDC, very in the first few weeks, that syndromic surveillance was far from perfect, but it worked really pretty well to predict, was it here, was it getting better, was it getting worse, which to me were the initial key questions. So that was one piece of the early duct tape and baling wire monitoring system. And the second piece was my colleague, the chief medical officer for Denver Health, mentioned to me that the CMOs of the area hospitals all have a conference call every day, and they exchange data on how many cases of COVID they have in their hospital. I said, can I get that? Can you send me that every day? And so every day from their or most days anyway, from their conference calls, check-ins. So that was the two parts of the surveillance system. And then I felt somewhat less terrible in having at least some ability to say, is it here? Is it getting better? Is it getting worse? And thinking back on the ramifications of that experience, one is we were fortunate to have this one tool called syndromic surveillance, and it worked really quite well. And of course, it didn't happen by accident. It happened with forethought and very careful work to build relationships, build a data system, build the ability to look across the whole Front Range at emergency department data. And we need something like that in a much bigger scale. And nothing to me makes any sense other than making that primarily based on electronic medical records. I think we have the data that will allow us to have a monitoring system for the future. We're just not using it. because we haven't put it together well enough. And obviously there are pieces we'll need that aren't in electronic medical records, but that has to be the basis of making progress there. So that was one story. The second story I'll tell is at several times during the pandemic at a local department, we were absolutely, completely overwhelmed with cases and contacts. Couldn't even come close to getting in contact with most cases, didn't even touch contacts because there was no ability to do so. And that happened actually with regularity, even though we expanded our staff to do that by, I don't know how many fold, 20, 30 fold increase in staff to carry out those operations. And in the end, what I concluded from that was the basic managerial strategy of do a few things and do them right. And I will tell you that I think we wasted huge efforts, huge amounts of funding, and importantly, just the mental bandwidth to deal with all kinds of things on case investigation and contact tracing. I think it was almost a complete waste of time. And we need to be honest as we look at the pandemic and say what didn't work and get rid of it, because it took a huge amount of bandwidth to manage. The third thing I'll come back to is the point you made very well, which is vaccination. And vaccination did go well, and it went well in our community through a lot of efforts. But the key was we got to throw out the whole rule book for giving vaccines. We didn't have to ask you, Ned, who is your insurer? Prove to me that that insurance is active today through an electronic system. Pay me a copay, et cetera, before you can vaccinate. We could vaccinate anybody. And we could vaccinate almost anywhere. So we vaccinated in the jails, we vaccinated in homeless shelters, we vaccinated in every place we could think of. And our success to a significant degree was because we could throw out the rule book. And we need to go from vaccines for children to vaccines for everyone. This is an incredibly cost-effective form of public health. We need to realize the success, and the success was being able to throw out the rule book. So some comments from me.
Thanks, Bill. Glenn.
Yes, Glenn Mays, professor in the school, chair of the Department of Health Systems Management and Policy. Thank you, Alfredo, for a very illuminating talk. I'm drawn to thinking about the system level issues that are that were at play and during the COVID-19 pandemic, and we already heard about several of these issues from our previous panelists. And thinking specifically about what Bill's just comments about how things played out here in Denver, I have to recognize that we're actually very lucky to live in Denver, to live in a place with a strong and dynamic public health system like we have here, and one that's strongly connected with the other systems that affect health and well-being, our medical care systems and social service systems. That is not the case in every place as you move across the country. There's enormous geographic variation in the capabilities that exist in public health systems, especially at state and especially at local levels across the country. The ability to do the kinds of things that you talked about, Alfredo, to engage in population thinking within public health systems varies enormously. The people who are trained to do population health thinking, working in public health agencies, especially at local levels, varies enormously across the country. The ability to have data at local levels and to be able to act on that data, to be able to analyze and link data rapidly to make decisions varies enormously across geographic areas. As you mentioned, I think the public health response here in the U.S., partly we were able to paper over some of those disparities in public health capability with a lot of short-term federal funding. We saw, the federal government ended up plowing in more than $5 trillion into the COVID-19 emergency response. And that certainly helped to shore up, at least temporarily, some of these gaps and disparities in ability to respond to at the local level. And it allowed, improvising systems to kind of paper over some of the longstanding disparities there. But also, as Ned mentioned, we're already seeing that federal funding rapidly drop off. We're back to a patchwork system of financing public health across the country. Places that have larger tax bases and can afford or have the political will to invest in public health enjoy much stronger public health systems than places that are not able or not willing to invest in public health. And so, I think that's in terms of the kind of long-term consequences. One of our concerns is that we're going to revert back to a decentralized, fragmented, inequitable, collection of public health systems around the country, and unless we're able to find, some ways to build on that. Again, I think another important aspect of the inequities that we see in public health systems around the country are the ability to actually meaningfully engage communities in planning for and executing responses to public health threats. Another major point in your talk, the ability to do bottom-up public health. That's also not instinctive to a lot of the work that we do. And it's not an instinctive approach to a lot of the systems that we have in place in the US. Again, strong public health systems have people who are trained to do bottom-up public health, to do meaningful community engagement, and there's a science behind doing that. Again, we're fortunate to live in Denver, where we have systems that know how to do that work. But as we look across the country, there are many places that are not covered by that kind of expertise and capability. And we need to think about how to close some of those gaps.
Yeah, I will comment on that. And I totally agree that we have a difficult situation now that the funds are going away. But I also believe that we've never been in such a good situation to claim for structural changes. And, I was in DC, we had a panel, and there was someone from Kansas. They said, well, our public health is very low and we still were able to vaccinate it. They don't recognize that they had this program with CDC who came and trained their pharmacists, and they built up the whole pharmaceutical response in the country with a really relatively weak public health sector. They don't say it, but we need to say it. We need to say that CDC, which is getting a lot of criticism, did a lot of great things, a lot of mistakes. I have no problem, but they answered very quietly, and they were able to guarantee that in particular some of the red states, the work was done and was done well. And the other thing that I report also in my book is that people say, you hear people saying, there is a growing distrust in public health. So, sorry, distrust compared to when? Oh, because are you talking about 2019? And there are surveys that show that when you ask people and ask even today to people around you, what is public health? And in 2019, most people, a lot of people in the US thought public health was medical care for the poor, right? I have private care, it's not for me. And when you say, yeah, but water, hair, etc., but is that public health? And so people didn't know what was public health. Today, people know. And we have a great response to this pandemic. We should build on it. We should claim that it's the moment to make those structural changes to be better prepared.
Thank you. Thanks, Glenn. All right, Chris.
Wow, so many good comments to come in last. As a third year doctor of public health student, really, my passion evolved over the course of COVID to focus in on our workers. And I started actually with a denial into my program as soon as COVID started. So thankfully, COVID continued my passion to get back into school and was accepted the next year. But I was involved with workforce development training here at the Center for Public Health Practice in that rapid first 6 months, trying to get workers out to the whole state. And it was really heart filling, I guess, and energizing that first year. And then we saw this deterioration, and I almost think of it as an epidemic of apathy that has continued on. And we lost, to Ned's comment earlier, we lost 30 health directors in 2 years here. Who are these other people that are being replaced, right? These are locally appointed individuals, and they don't have to have a high level of training or degree to take the helm of a health department. So what decisions are we not aware of aside from these ones that are pretty apparent? And then with the funding cutoffs too, we're losing these thousands and thousands of workers that we did get in. We're losing them daily with these drop-offs. And recent, studies on MPH grads are showing them not really interested in going into governmental public health, which is a little worrisome. They're going to nonprofits and things like that. So there's definitely discussions around how do we think of the public health system as more than just governmental, this non-governmental public health system as a part of us. But I most recently just want to comment on your positive note on we can't give up on people with different political ideologies because public health fails if we do that. And recent work with the Cancer Center, we were interviewing public health departments around population health approaches to cancer. What are they dealing with? Are they still doing tobacco prevention? What's it look like in this post-pandemic world? And they're overwhelmed with a lot of issues that I feel a public health agency is going to struggle with to deal with. One of them, they're being asked to solve housing crisis, right? They're being asked to deal with intense substance misuse problems and mental health problems. So we're also seeing these traditional public health pillars like vaccines and cancer prevention taking a back seat a little bit. And so I definitely hope to see this push to have conversations and cross that aisle and recenter the value of public health. I think economics is always something that gets Republicans involved because public health is a sure bet. Funding wise, we are a minimal and fractional piece of the larger clinical realm, but we have the largest return on investment. And so I definitely lean on that with trying to have conversations with people who maybe see things differently. And I'm hopeful that that is something we continue to push on. And I also appreciate you mentioning leadership training because the leaders, I'm hoping to be one day, but it's not something that happens overnight. I get to learn from so many fantastic people, but it takes years. And so what are we losing when you push someone out for political reasons that was in a community for 10 years? They know the ins and outs of relationships. And so it's worrisome, but I appreciate your positive notes on things because I do think there is a lot we can bank on and we still are a pillar of our community's health. And then I'll just say too, I do hope aside from community engagement, that we also see a little bit more advocacy and alignment and support maybe from our clinical colleagues in general, right? Because we saw what happens when public health starts to crumble, so does our clinical systems. So I think there's definitely room to grow in terms of our public perception as being more aligned with clinical healthcare and the role of healthcare as a full system. So many thoughts though, and I appreciate the opportunity to be here.
Oh, that's great. And I didn't talk about the public health the workforce, but it's of course one of the most dramatic phenomenon that we're observing. I mean, there's an hemorrhage and we've lost, I think, 30% of the workforce. It hasn't come back. The fastest growing sector of the public health workforce is community health workers. They've increased, but they all soft funded, they funded on grants, etc. We're going to lose them too because the hospital sector, can swallow everybody in the field. And so I think there's really urgency there. I was talking with Dean Bradley about the undergrad degrees in public health. They are also a very fast growing sector. A lot of young people interested. If we can use that space, there is also funding and support for School of Public Health to do that. We may, try to refill the MPH path, etc. And so that's a very, very important problem, and we need to have it to mention it as a priority. And also, having unions in that sector, not letting them being overexploited. So that's key. I want to say just one last word about what you said about the system and the importance of prevention. Our system, which is essentially based on cure, that's medical care, prevention is failing. I mean, during the 50s, 60s, 70s, we may have not have seen that because the salaries were there. People could pay for their insurance, for the high quality care, etc. But now we have a decline in life expectancy. I mean, at every age, people die more. That's just an incredible phenomenon because it's rare to occur in any population since the 1900s. Life expectancy, goes up. In USSR, when the USSR, we had a decline there, but here in the United States and even in the most privileged sector of our populations, middle class, etc., seeing this is the proof of the failure. And so that's another element that we need to use since the system is funded at 70% at least by public funds. The healthcare expenditure is covered 70% by the government. That's the truth. It's my colleague Colin Grogan just published Hide and Grow. It's a book in which he shows that if you count everything. And so we need to change that system because it's failing, and maybe that's new too.
Okay,
Just a quick comment. We have copies of the book that Alfredo has been referring to outside, and I suspect he'll sign them.
that's the case. Okay, so thank you to the panel. Thank you, Alfredo. I'd like to open it up to questions to the audience, both in the room and online. And we'll start here.
Can you hear me? Okay, my name is Ola Kokoi. I'm a first year doctoral student with Community and Behavioral Health. And my day job is I'm an administrator for the Pathways to the Integration of New Americans at the City and County of Denver. I really enjoyed what you've said, and it really resonates with me. And I'll just want to piggyback a little bit and share my experiences during COVID-19. I know that the BIPOC communities were seriously undermined and they were really impacted with COVID. And I wear different hats, as also I'm a community leader within the African community. I'm also one of the commissioners for Denver Immigrant and Refugee Commission. So I was very much involved, especially during COVID-19 and also during the vaccine distribution. I remember how much I have to go all 9 yards to make sure that my community able to get the vaccines. And I knew that you talked about successes and failures. The successes, of course, is that we are here. None of us is wearing a mask. We are not doing everything online. That's a success on my part. That's a good one that we are here in person. But the failures too are there, and we shouldn't overlook that. The failures in the sense that the narratives, when we were, the public health committee were not controlling the narratives, kind of, because we had a lot of misinformation online, which was accessible to a lot of people who knew little or nothing about public health. So that was, and that really affected the number of people who took the vaccines. But in my part, I was able to, talking about community engagement, work with Denver Health, I worked with the city, I worked with different organizations, and we were able to, and also worked with at the state level to make sure that we were able to provide vaccines to a lot of people in the immigrant community. One thing I was able to, I remember was the fact, the issue of CDC giving pharmacists the opportunity to give vaccines. I did capitalize on that. I had a local pharmacist who had a pharmacy who people in the immigrant community felt comfortable to go to her. I was able to let Denver Health say, you need to work with this pharmacy if you need to reach, because I was contacted to see how they can reach out to the immigrant community. And I said, even though I'm one of the doorkeepers here, but you need to work with local pharmacists. And they were able to do that. And through that partnership, she was able to give out over 1,000 vaccines within a period of 2 to 3 months. So that is just my own little contribution, but it was not easy. People were dying back and forth. And one thing I also really appreciated you saying was that population health. Public health is population health. It cuts across all races. But we are still today having the fact that the BIPOC communities, especially immigrant communities, are still not embracing public health the way it should. Even by those of us here, I'm the only person here that looks different from other people. And it's because it's not been embraced as much as it should. People tend to embrace more the curative medicine like nursing and medical, all the medical fields, but not public health. But we need to work together if we need to have what you call holistic health. So I really hope that moving forward, we shouldn't wait for another COVID to hit or any other viruses to hit before we are able to bring those who are across all races to the table, not just for them to work in the community, but for them to also be on the decision table to make the decisions, and because they are the best people to speak for their community. Thank you.
Thank you very much. Thank you for sharing your experience, and I totally agree. I mean, if you're not at the table, things don't happen, and it's very important. One thing I just want to say is that I totally recognize that there were big failures. You know, I'm trying to see the bigger picture, but there was the failed test from CDC. There were all the false ideas that COVID was transmitted by surfaces, etc. I mean, there were lots of mistakes. It's sure, but despite this, I think we were able to devise a very effective. Everything you say about equity and the necessity to integrate people from the various community in the decision level, I think it's essential. Without this, we cannot build a real strong.
One else?
Doctor, I so appreciated your talk. I think everyone here who went through this and was part of the team trying to deal with COVID-19 left really with our hearts very heavy. And to have that retrospective where you focus on the positive, I think it's really important for all of us moving forward. I particularly liked your emphasis on individual versus population, because I think it also talks about how generationally we have changed, right? So I'm a boomer. I was in that 65 plus when COVID hit. But I also grew up during the biggest breakthroughs in vaccines, the polio vaccine, the smallpox vaccine, and the greatest generation were my parents. And so they grew up in poverty, and they grew up in this wonderful opportunity to keep their kids healthy. And they embraced that. And so did we. And so when we started seeing COVID come around and vaccine hesitancy, I just couldn't understand it. Why would you turn your backs on the greatest breakthrough in preventing this horrible disease? It just doesn't make sense. But when you think about it, my parents' generation, they were brought together as a community because of the war, right? So they lived community life. They lived neighbors helping neighbors. We were taught that as children of that greatest generation to help our neighbors in times of need and to do the right thing, not just for yourself, but for everyone around you. Well, things really started to go downhill after the wars it faded into our deep perspectives until Ned brought up what happened, post 9/11, right? 9/11, we then had the anthrax attacks and people jumped on that ballywick. Well, they jumped on that ballywick because of 9/11. I don't even think it was so much the anthrax attacks as it was the fact that the entire country banded together as a community, again, that sense of community, to do the right thing and get prepared. And so I think you have a really, really important lesson learned that we, as we move forward, need to focus on that and focus on educating kids about this community perspective. Because how many of us have had our own children lecture to us about something they've learned in school, right? And so if we can turn the consciousness of kids in school to be more community focused on the big picture and not on every misinformation that you have come across through whatever social media outlet you've looked at today, that would go a long, long way. But thank you so much for your perspectives. It really made my day.
Comments, questions?
Thank you very much for the talk. My name is Peter DeWitt. I'm a research professor in biomedical informatics and a proud graduate of the School of Public Health and Biostatistics. So I'm glad to be here. I wanted to share an anecdote about communicating and fighting against misinformation from my experience with COVID. So I was very fortunate in my professional capacity that I had access to a lot of data on COVID, including the National COVID Cohort Collaborative, N3C, roughly 100 hospital systems, all of their data in one place to study COVID. And I spent a lot of time on pediatric COVID. And my neighbors knew this is what I was doing. They knew I had access to the data. They knew I was working on it. They knew I was writing reports that were going up to the NIH and to the White House task force on COVID. So they knew I had this information and this knowledge, and they didn't believe a word I said. But that slowly changed over the course of pandemic for some of them. And my takeaways and the difference in the way I communicated with both my family and my neighbors in retrospect is pretty telling. My younger brother couldn't be more different from me. COVID was first a conspiracy theory. Interestingly, because there weren't enough deaths related to BLM protests, so it doesn't affect those of color. It only affects whites. Rabbit hole so deep, I couldn't convince them of anything. But a couple of my neighbors were very hesitant about getting the vaccine for themselves and their children, and I talked to them a lot about all of the concerns about the inflammation around the heart, it's because they had two young boys, and all the other issues. And what I found between them and one of my other neighbors is if I ever said something like, you should get the vaccine, done. Conversation is over. They're closed because they're not receptive to this yet. They want the information. And what finally helped get my neighbors to take the vaccine, protect and get it for their children, was that we had many, many, many conversations. And I would always include something like, the vaccine is still the best protection available against this variant. The vaccine is still performing very well against this variant. Yes, there's a new one and the tests aren't done yet, but we have this information and it still looks positive. And I would just talk about it in very general terms and help them feel comfortable eventually making their own decision, or at least what they think was their own decision to get the vaccine. And it takes time. It took 14, 15 months after the vaccines were first available for them to finally do it, but they finally did it. So yeah, it's a struggle. You can't convince everybody, but take your time, stay patient, keep an open line of communication, and from a bottom up perspective, we can do that. And hopefully not for another pandemic, at least not in my lifetime, hopefully. But if it happens, I have a idea about how to communicate. Thank you.
Thank you very much. And I mean, your experience